Great, thank you. I realize we're running late and we'll probably won't get time for questions, but I think all of us will stand up here. My talk is 11 minutes and I'll try to talk a little faster, but please stick with us because I have an interesting talk today and I appreciate my PGY4 and also Dr. Samadov, who was here last year at SAGES, a colleague who works in real time in low resource settings. There are no commercial support to be revealed, but I want to disclose that the opinions of this, which might be a little controversial here and there, are of that of the author, which is me and my resident, not necessarily of SAGES or Go Global, but this talk is designed a little bit differently to make you think about what is reality and what we should be doing. All right, so I did provide a list of references if you need them. So as we've talked about today, the basic pillars for ethical global healthcare delivery is really to build trust with the community, with cultural humility, provide ethical, skilled care within cultural norms. Part of that is educating ourselves and finding partners there who are willing to, shall we say, confront us and educate us with what appropriate cultural norms are. When you're teaching in Africa, for example, the resident does not question the attending, even if he or she says something controversial. Looking them in the eye is considered confrontational and a disrespect of their authority. So if you want to bring up something we do at rounds, sometimes I say something wrong just on purpose, and I get hands and people jumping down. That is totally unacceptable in other areas. So you may deliver inappropriate information, not realizing that they will not understand what you're trying to do in your teaching methods. Follow-up and support for the present, sustainability for the future, consistency in delivery and meaningful timing. A once a year drop-in clinic does not mean it's meaningful timing. And education to provide self-determination. We all know this. Our resources are limited. We've gone through that several times today. Developing partnerships in education, develop responsible relationships. But we have to remember to respect where they are at and ask the question, how can we help you? It is really challenging for me, depending on what group I go with. These groups feel like they're the spaceship that come down and drop healthcare in a benevolent kind of way and feel that they're doing some good. And we really need to ask the question, what is it you need? We need a targeted needs assessment. What do you need and how can we help you get there with what you've got? We already have heard these stats, but I'm going to add some more to this. 60 to 85% of biomedical engineers, if they exist, receive no medical training for this donated equipment that they receive. And there's a 30 to 80% reduction in useful life of this equipment that we may donate due to inexperienced operators and lack of repair. And if you want to delve more into this topic, this article by Dr. Marks out of the UK has a lot of really good statistical data that he's done a multi-study analysis. What is the burden to recipient country? We're going to talk today about donations and expired material. That's what this talk is going to segue into. What's the burden to the recipient country if you donate something that doesn't work or runs out? How do they dispose of that? And what cost does that cause them to do that? What are our infrastructure gaps in biomedical tech? And shockingly, some of these stats will come out to you. 40% of donated healthcare equipment is already out of service within a few months of being operational. The World Health Organization estimates an inordinate high number of medical equipment is donated. And for example, in Nigeria, 70% is donated, but only 10 to 30% ever becomes operational. What the heck? What are we doing to these countries by donating equipment that never gets used? A third of donations appear without any targeted needs assessment, no consultation. We think you need a mammogram unit, so we're going to send you one. Isn't that great? And that's really inappropriate. And this is like, you know, at our local Salvation Army, 60% of donors provide broken equipment. Like that's me sending a moldy, holy sweater over to Salval and hope somebody else wants to buy it. Like that's pretty ridiculous. But that is exactly what is happening today in these countries. So this is a picture of a suitcase that one of my residents was packing regarding equipment. What is our definition of expired equipment? And if we are passing on expired equipment, is that really is that a fallacy, or are we given substandard stuff? Or we all kind of know, nudge, nudge, wink, wink, that expired doesn't really mean expired, does it? Does it not? What does that imply for the people that we are serving in these countries? In my experience, where do we track where things go? The red tape. I've brought more than one suitcase through Haiti's customs and had things just plucked right out. Ooh, I can sell this. Ooh, I can sell that. And a third or half of my equipment is taken by the officials at customs so that they can sell it on the black market. So how are we helping that situation by our donations and smuggling things in our suitcase? Regardless of what we give, who is on the receiving end, how are they receiving it, and just giving it, does that really absolve us of any dilemma? And it's up to them to figure it out, because it's not my problem their government's corrupt. So why don't we just give it to them and see what happens? You know, at least it's better than nothing. And so as Dr. Fisher talked, if we don't give it to them, they will alternatively try to make it. This is a couple studies here. This one's back in 2003. But then there's one in 2008 and another one in 2020 using mosquito netting for mesh. However, very interesting study came out in 2018 looking at not all mosquito nets are the same. In certain countries, depending on the origin of the mosquito netting, this is the degree of sterilization for most sterilizers that are available in low and middle income countries. And if you sterilize it to the appropriate amounts, the polymer basically melts and dissolves and becomes a hard piece of plastic. So you have to be careful even where you get your mosquito netting if you're going to try to use that for a hernia repair. It's not all the same. Again, sounds intuitive, but we need to drill this home. This is a conceptual model developed by Dr. Marks about collaborating and doing targeted needs assessments, looking how sustainable that equipment is that you donate, operationalizing it, training it, and then most importantly, getting feedback. Did this donation work? Is it still working? And how can we promote more of it if it is functional? If you don't do that feedback loop, you're really not completing the process. So again, we've talked about our global work. I won't, in the essence of time, belabor that, but it's pretty amazing. But I'm going to bounce back off that a little bit later. Simulation works. We know simulation works. We've seen it in our own way, and it's been proven by this very nice study in 2018. But I think we're forgetting a key part of simulation: how to use the equipment, how to maintain the equipment, how to sustain the equipment. If we're teaching them how to do a lap chole, but we don't teach them how to troubleshoot. I don't know about you, but when the nurse comes to me and says the Bovi's not working, I go, yeah, it's not working. Call somebody who knows. Like, I can't even troubleshoot half of my own equipment, right? How do I get the harmonic scalpel? So if that, now multiply that times 1,000, and nobody has a clue how this stuff works, and you're not really helping them sustain the future. So that's really important, to add simulation geared toward equipment in our simulation trials. And I encourage the Go Global committee, upon which I serve, to think about that. We also can support indigenous solutions like the Japor foot, which is very famous, and the bicycle centrifuge, which labs use now to centrifuge their blood products. Pretty cool stuff that's out there. This is a very elegant article about medication use and expired medications by a nurse practitioner. And I'll just summarize her conclusions, which that means we need to provide more clear guidance to low and middle income countries when to consider using expired drugs. We need some guidelines. When is it really expired? Is it not expired? What's that definition mean? Is the expiration date mean lower efficacy, or does the expiration date mean dangerous byproducts? That's a big difference. If I have to give 2 Percocet because they're expired, that's different than if I give an expired medication that now has broken down to products that become toxic. We have to define what expired means to that product. And there really needs to be a global call for evidence-based expiration dates that are more realistic and track the safety and efficacy data. What happens a year after the expiration date? Does the amoxicillin still work, or is it going to poison that child and make it unusable or actually unsafe? Good intentions are not enough. This is when I was in Haiti, and this is one of our mammogram units that's been sitting there for 3 years, sent there because nobody knew how to take it out of the bubble wrap and hook it in and how to use it. So good intentions are not enough. This is from our colleague, Dr. Samadov, who's a fellow of the American College of Surgeons, but he is an oncology surgeon that does hepatectomies and gastrectomies. I actually had a video, and in the essence of time, I cut it out. This is his nurse filling staples into reusable GIA stapling devices and then sterilize them. Literally hand filling from this bucket of staples into his staple. They use duvet covers, pillowcases, sheets in order to have sterile drapes in some of the war areas. This is his cotton suture that they close the skin with. That's a glass of alcohol that they use to sterilize it. Is that unethical if we get there and see that? Are we contributing to that, or are we building upon the cultural relationships and norms? As Dr. Fisher approached, when I was in Haiti, these are the Bovies soaking in a bucket of alcohol. If I look at that horrified, they're offended. But is this good? Is this bad? The Bovies still worked. This is my very well reused pad, the bypass pad, and this is us handing off the Bovie to be used in the sterile field. And I have dozens of pictures like this. Now, having said all this high and mighty stuff about expired materials and what's ethical and what's normal and developing all these good relationships, let's go to reality. Reality is this guy works. He is the sole breadwinner for his family, and he's a laborer building concrete. He's the breadwinner for his family. You have this piece of expired mesh that you smuggled over in your suitcase that the customs people didn't steal from you. There's this repair called the nylon. I found this one, the Maloney Darn nylon repair, which kind of says, I can't get the floor closed, but I'm going to use sutures to try to build it. Are you going to use mosquito netting, which may or may not be sterilized appropriately or effective in the long term? Or are you going to use this expired mesh because it expired 6 months ago? And when you look at the package, it's intact and its integrity is there. What is the reality of what you're really going to do when you're in these countries, and what is ethical, what is appropriate? And I think we are way behind the curve in really determining that as a global healthcare situation. So in conclusion, build trust and communication. When you're developing relationships with your physicians, also develop relationships with partners in the field who can be procurement managers, who can tell you what's feasible and what isn't, how to repair the laparoscopic equipment. Foster those partnerships, respect the norms, and this one I find a little bit controversial, developing ethical guidelines for expired materials and informed consent if you're going to use expired materials. Now that begs the question of what is informed consent when all you have is an expired drug or an expired mesh? Is that really an informed judicial equitable consent? That's a controversial topic. But if you do use expired materials, you need to be transparent about what you're doing with the local administration. So thank you very much. I appreciate your time.